Hello. Today we're going to be talking about medication adherence challenges and solutions regarding Medicare recipients. So there are two main causative factors that we should be looking out for, but in there are sub factors that contribute to low or no medication adherence among elderly and Medicare recipients. So let's take a look. So, as under socio-demographic factors, lack of education on medications and costs are those factors that contribute to low or no medication adherence. Socio-demographic factors are generally seen as adult patients who are younger or members of racial and ethnic minority groups, unmarried, or immigrants are more likely to be non-adherent to prescribed medications for controlling chronic diseases, including diabetes. Bussell et al. 2017. So next we're going to be looking at psychosocial factors. This one right here. There are three sub-factors: distrust in the medical system or in medications, polypharmacy, which is the use of more than one drug, in many cases there are four or more with elderly patients, as well as depression. So, psychosocial factors are patients who are experiencing negative emotions such as dread, self blame, guilt, helplessness, and frustration. They're more likely to fail to take their medications. Sometimes patients purposefully do not take their diabetes prescriptions if they deny having the condition, namely new patients, and are frightened of side effects or perceive a lack of immediate benefit from those treatments. In many cases, those are asymptomatic patients. Also, patients' cultural views about health, diabetes, and medication are used in additional factors that contribute to deliberate medication non-adherence. Patients are frequently hesitant to discuss their plans to discontinue drugs and their concerns with their healthcare providers. Other patients self-adjust their medicine by trial and error, which is not great. Bussell et al. 2017. So, in order to tackle these problems, we do have to use nursing theories and other theories to help understand what's going on and give us a process on how to solve these issues. The first theory that I initially wanted to use was Erickson's theory, namely more integrity versus despair, since Medicare recipients and elderly populations tend to be in this stage of life. So, integrity versus despair. Erickson defined it, Erickson 1982, page 112, defined it as a retrospective accounting of one's life to date, how much one embraces life as having been well lived, as opposed to regretting missed opportunities. So, what do we look for when screening elderly patients in the scope of using Ericksonian principles? So, I found this inside of an article that I read from Gerben et al. 2017. Extroversion and openness to experience having an indirect relation to ego integrity that is mediated by well being. Neuroticism was related to despair and explained the relationship of depressive symptoms to despair. So there is a way to use these theories and figure out which part of the stage of integrity versus despair they're in, and we can use that to our advantage and try and connect with our patients and figure out what's going on. It may lead us to find out that they are in despair or depressed, and therefore we can act on that and be sure to tailor make our care for these patients in that sense. So the linkage between Erickson's theory and the clinical problem is really that Erickson's theory shines a light into what stage our patients are in and how we can assess them. I believe that we do need to know how our patients are feeling in order for us to treat them correctly, and we need to be treating these people like people. Let's move on to the next slide, shall we? Orem's theory. So Orem's theory is a bit more complicated. It's more involved than Erickson's theory and more hands-on, and it handles internal and external factors, which is why I decided to ultimately include this one. There are three main aspects to Orum's theory: self-care, theory of self-care deficit, and theory of nursing system. And Orum's theory really masterfully links to my clinical issue because, well, let me show you. Because medication adherence is central to the theory of self-care. They they link in instances where it is crucial for the provider to find or assess for the deficits in self-care, namely when a patient has veered from their medication regimen. Orum's theory encourages the nurse to find practical interventions that help their patient return to their peak function for the achievement of self-care. After the nurse finds these solutions, it is time to implement interventions and then reassess for efficacy. Orum's theory allows for tailor-made care in every patient and ultimately allows for them to achieve their self-care goals. I think it is important to assess and use a nursing theory for this matter. So let's go on to the next slide, shall we? So in Orum's theory, self-care requisites, there are 5 of them. And the last two, prevention of hazards to human life and well-being and promotion of human functioning, I believe really connect to the clinical issue of medication non-adherence or low adherence. Um, Medications do promote human functioning in some instances. Sometimes life-saving diabetes medications are needed, and they do promote functioning, as well as a lot of medications prevent hazards to human life and well-being. Therefore, I believe these two parts are very good for connecting to my clinical issue. So, Orum's theory of self-care deficit. Let's explore that, shall we? So, this theory's component, self-care deficit, indicates when nursing is required. According to Orum, it's required when an adult is incapable or limited of providing continuous effective self-care. The approach helps us identifies 5 ways to assist others. Uh, Sometimes it's directing, sometimes it's supporting, sometimes it's providing a good environment for these patients or teaching, which is very important, especially since a lot of patients do not understand their medication regimens when they leave the office or the hospital. So there are 2 main themes to Orem self-care deficit. The first is interpersonal or social. Communication in this category is tailored to the individual's age and health status. The nurse assists in the maintenance of interpersonal, intergroup, or intergroup ties in order to coordinate efforts. In light of the psychosocial styles of functioning in health and sickness, the nurse should also maintain a therapeutic relationship. The nurse provides human support appropriate to human requirements, activities, talents, and limitations in this area. The second type of technology is regulatory technologies, which supports and encourages life processes. In health and disease, this category relates to psycho and physiological patterns of functioning. Nurses should encourage human growth and development while also controlling position and mobility in space. Let's move on to the next slide, shall we? So these are the main interventions that I found in these scholarly articles for um, for helping with low to no medication adherence among seniors and Medicare recipients. The first 5, telephonic interventions, trust, polypharmacy, education, and cost. So when we look at this, telephonic interventions is just a tailored telephonic intervention implemented by healthcare educators, and it was actually found successful in a 1-year trial. It improved diabetes control compared to with a print intervention in a low-income insured minority population. Large-scale trials spanning the last 2 decades have shown that improving glycemic control in type 2 diabetes dramatically reduced the risk of major chronic issues such as retinopathy, neuropathy, and nephropathy. The research goes together with smaller trials to lay down the groundwork for evidence-based diabetic care practice. Despite the development of successful management therapies, treatment goals are frequently not met, particularly in low-income and minority groups, and many people find it difficulty to do routine self-management. Walker et al. The next one is distrust in our system. Trust is built over time with the same healthcare provider in a relationship in which patients believe that the healthcare provider is competent and genuinely concerned about their health. When patients receive unrealistic, disrespectful, or insensitive counsel from their healthcare providers and experience emotional distance from them, mistrust develops. Bussell et al. 2017. The next one is polypharmacy. Polypharmacy for individuals who take many drugs, streamlining the prescription schedule can considerably increase adherence. Adherence and dose frequency are adversely associated to adherence, which each additional daily dose decreases adherence by 10%. As a result, healthcare providers should use once daily dosing if practical, simplify the timing of prescription drugs, and reduce the number of pills taken each day by using combination pills when available. If once a day of dosing is not possible, synchronizing medication taking times to patients' activities of daily living may increase adherence. Encouraging patients is also important, perhaps asking them to get a pill box that is more convenient, as well as having the refill dates happen all on the same day. Another good way to help improve would be using mail order pharmacies for chronic drugs that can improve adherence significantly. Bussell et al. 2017. The next one is education. An estimated 35% of Americans lack basic or sub-basic health literacy, making it impossible for them to read a prescription container or just difficult. Adopting universal warnings against medication non-adherence and low health literacy is beneficial as it encourages healthcare practitioners to presume that patients are not taking their medications as prescribed or may not understand the printed directions unless proven otherwise. Each patient should be given clear and written spoken directions on how to take each drug. Goman et al. Cost. Providers are frequently rushed during their appointments and are sometimes unprepared to cope with patient-reported financial restrictions. Some ways to tackle this would be to give simple solutions, such as giving online resources like GoodRx, OneRx.com, things like that to help reduce the cost of getting the medications in the first place. Or begin conversations such as, affording medications is difficult for many of my diabetic patients. Do you have any trouble with this? Use less expensive generic alternatives, or examine pharmaceutical aid and savings schemes such as rxassist.org, pprarx.org, etc., and learn about local assistance programs. So let's move on to the next slide. So I believe I found the theory to be appropriate. More specifically, Orem's. I think I favor that one. I felt that it would not have been able to use just one theory. I felt that the usage of Orem's and Erickson's helped me understand the psychological and external variables that affect medication adherence. Therefore, both theories as a package deal were appropriate to use. Although I do wish I could have found more on Erickson's screening measures, I did get good insight on which behaviors mean what, and I feel that elderly depression could have been a viable concept to create interventions for, but I felt it would be too parallel to integrity versus despair. Therefore, I bunched it in. I did not find conflicting information other than some interventions that seemed a little similar, like automatic messaging intervention and things like that. So, balance of the identified evidence. What was the balance of the evidence? I found it to be pretty well balanced. The balance of the evidence I discovered tended to lean more towards Orem's theory of self care. My clinical question turned out to be a topic that many individuals in academia talk about, which was nice to hear about. The evidence I used seemed of very high quality. The randomized trial showed that telephone calls to the patients about their medications, as well as concerns, significantly improved their medication. Um, let's see. As far as conflicting, I do not believe I found any conflicting findings. Implications for nursing. Nurses can perform all kinds of interventions that I've stated. Nursing practice should be available to evaluate and assess elderly populations so we may find how we can help them. Nurses can employ strategies such as telephone interviews or help seniors learn more about their medication regimen, things like that. And we as nurses are the most trusted profession, and I feel we can establish trust and lasting relationships with our senior populations by doing what we have always done. So, practice changes, as far as those go, I would advocate for visiting nurses to help go over medication regimens, cooperating and communicating with pharmacy to simplify medication regimens, and to educate patients, as well as setting up cost saving accounts such as GoodRx and other systems to address the cost barrier situation. The questions this raises is, I think it's, I think the biggest question is, where will the professionals find the time? It's been stated in some of these studies that already that they have to find the time in order to educate patients over the phone or make their calendars or scheduling longer per patient. And which I'm not against any of that, but it may contribute to our providers who are already strained to see less patients and therefore care for less people. So I think it would be interesting to see how we adapt to this change. Working in healthcare has shown me that nurses, doctors, and pharmacists are extremely busy too. So follow up calls tend to be brief and impersonal at times, and I wonder if we are going to grow into a more personalized standard of care when it comes to medication adherence or in general. Sometimes I wonder if they would fit in real world situations. And I imagine hundreds of follow up calls would be need to made for large pharmacies like CVS, and it makes me wonder if it's even viable. I hope it is. Large hospitals may need to make these follow up calls too, with tons of their patients that they see every day. And perhaps it is best if these responsibilities go to the home nurse when possible. So yeah, uh, hopefully with these interventions, we can increase medication adherence throughout our little corner of the world. And thank you very much.